I'm Dr. Krishna Prasad Kudlu. Sabrina, let
Yes,
us
doctor.
start our session on ZEISS.
Yes,
It is up
doctor.
to the newer technology from ZEISS. We have got a good lectures coming in this particular session to tell about the technologies from ZEISS. Along with me, Dr. Partha Bishwas is the chairperson for this session.
Yes, doctor.
I'm moderator for this session. So we have got a galaxy of speakers to start with Arut Bhuvnik. Then he'll be talking about achieving desired refractive outcomes using IOL Master 700, followed by Dr. Naren Shetty. Then I'll be talking. Then Dr. Sartaraj Grewal and followed by Dr. Neeta Shah. I could able to see Neeta Shah is already logged in. So to start with, I think I invite Dr. Arut Bhuvnik. He is a prolific surgeon, phaco-refractive surgeon from Kolkata. I've been part of their hospital. Last I've been to their hospital to do one live surgery. Fantastic hospitality. I welcome Dr. Arup. Yeah, Arup, you can go ahead. Arup.
I must thank AIOS for this wonderful meeting in this difficult time. Can you hear me? Hello?
Yes,
Hello?
doctor, we can hear you.
We can go ahead.
Okay.
You're audible.
Yes. How to achieve the desired refractive outcome in case of biometry? You have to have a perfect biometric technique. Your technique must be very right selection of IL calculation for each cases, and compare outcome of different formula for the premium IL. And review of clinical patient clinical condition is very important, and in possibility it is to maintain your own data, your own database, and absolutely red flag whenever you get some kind of refractive surprise. And definitely there is an importance of review literature. It will guide you how to go ahead with the future. And most important is a biometry machine. Let's look out the quick look out the what we have reached so far in the biometry formula. So we start from the SRK2, it's a regression formula to the Virgins, and now we have the fourth generation formula. Here is a Barrett universal to the most popular, and the AI-based formula, the Hill RBF is also coming very fast. It become very popular in nowadays, and we have another formula. But for this, you have to have a different variable. For Barrett, you have needs a 5 variable, and Holiday to have a 7 variable technique. Though the Hill RBF is not an actual formula, it is a AI-based pattern recognition formula. So we have a long journey from we started our biometry from ultrasound to optical sweep source B-scan based biometry. So far we reached. And what is the ultrasound biometry limitation? It's a variable compression, corneal compression factor, bond sound bin without precise location, and limited resolution in some cases. Remember that the ultrasound speed is different. So in a Morgagnier cataract, through the cataract is its speed is different. To the grade 3 cataract, the difference is ultrasound speed. So there is always a variability in the axial length, and study shows that most of the wrong biometry basically due to the axial length when there is we used to use a ultrasound biometry. So now we're using optical biometry. These are the optical biometry of one of the infrared source, and this is the available ZEISS platform has a ILMaster 500. It's an optical biometry, and sweep source biometry is ILMaster 700. That we are using. I am using almost last more than 1.5 years. So this is the principle of the ILMaster 500. It's a partial coherence interferometry. But in 700, it has a sweep source, and it can able to do 2000 scan per second, and in a different angle is a 0 degree, 30 degrees, 60 degree, 90 degree, 120 degree. Within a half a minute, it can do everything. 2000 scan almost every angle. So what is the problem of the conventional biometry? Conventional biometry often fails to do a biometry if there is a PSC, posterior-subcapsular cataract in the nodal point, or it is inability to penetrate the most of the advanced cataract. Whereas in Schweppes biometry, it can penetrate the even very mature cataract where I never expect to get the biometry previously. So what is IOLMaster 700 giving? It's a measures axial length. It measures 3-zone anterior keratometry, telecentric optics. It's posterior keratometry, total keratometry, ACD, AQD, aqueous depth, lens thickness, CCT, white to white, angle kappa, angle alpha, and reference image work. This is much more what your standard optical biometry is giving. And that is absolutely new, is a posterior keratometry and total keratometry, which is not available so far any other Schweppes machine, Schweppes biometry. It also gives you angle kappa, angle alpha, and it's an excellent system we get for the reference image for the markerless surgery. So it's a OCT B scan. Why it's a B scan? It's give a 6-angle OCT scanning. It's like a star pattern in the B scan, and once it's captured the data from axial length to CCT and keratometry, white to white fixation check, and larger Vettel is a green image for the markless, and it just captured is within almost half a minute, and that data is analysis. There is a fantastic analytical software inside, and that analysis what you can get in the IOLMaster 700 more than you expected. And the most beautiful part is you can check what you are measuring. You can check, you can view what you are measuring, and most important thing, it has a excellent quality check. If it is a green sign in everywhere, you automatically it is successful. It is successfully measuring the thing. And if you get borderline problem, you have a green, use a yellow signal, and if it is a measurement failure, it will give you a red signal. So it is automatically warning message and support the decision making. And green and orange indicator easily check the measurement at a glance. Whenever you measuring the axial length, it is actually giving the absolutely foveal hit the fovea, and you get the actual axial length, and you can check the foveal pit in your every scan. If you quality check, if you know foveal pit, so there is a poor fixation. And again, you can get a clue. If somebody not doing the routine OCT, he can get a clue and undergo the OCT. Mind it, this quality of OCT never a substitute for the actual retinal or macular OCT. It has a beautiful refractive, 3-zone refractive keratometry, 3-zone the telecentric keratometry. This is 1.5, 2.5, and 3.2, and it gives a spherical equivalent K1, K2 axis, and mean K and axis in the anterior surface and the posterior part surface. And what is the important is they're giving the total K, and the vector analysis give the axis of this total K. And there is a quality check also in the telecentric keratometry. You can see that if there is a dot is missing, there is insufficiency of blinking. You can get this kind of picture in cases of dry eye. You can easily postpone the biometry, and you can treat the dry eye, and can ask the patient to come later. The total keratometry is almost the wonderful thing. The 3-zone keratometry, telecentric keratometry, they measure the CCT in that particular place, and they make a 3D posterior 3D point, and they say make a posterior torus field, and apply the calibration and posterior values, and apply the power of matrix of thick lens formula, and you can get the total keratometry. This is a wonderful thing, and it is only available in AIOLmaster 700. You can, Douglas Cock already presented his study in 2012. After that, we have learned how important is posterior corneal astig protection in case of toric oil implantation. The view of corneal aberration, you can one spot they give it's a analysis of posterior curvature and anterior curvature, and it's a give you the total axial map of the cornea. The central topography of the 6 millimeter AIOLmaster is giving, and it is giving only less than a 45 seconds. See, this keratometry never replaces the actual topographical keratometry, but it's give you a rough idea whether you go for the topography and whether the patient is suitable for the multifocal IOL, premium IOL, that is multifocal IOL or toric IOL. It also gives you the angle alpha and angle kappa, which is very, very important in case of multifocal IOL or trifocal IOL. And you have a galaxy of all kind of formula you can compare with this, and most importantly, new is this machine is give you the Barrett TK Universal 2, Barrett TK Toric, and Barrett 2K Toric. Now, what are the formula you can use the TK? You can use Higgins, you can use TK, you can use Barrett TK, you can use Higgins T with TK. So with the TK, including the TK formula in this calculation, it gives a better result. It has a Barrett suite, all kind of Barretts except Barrett RX. It's all formula. Barrett RX is actually not the formula, it's a planar. But after apart from the Barrett RX, it gives all kind of Barrett formula, and this Barrett 2K Universal 2, Barrett TK Toric, and Barrett 2K with TK is not available in any other machine. Now let's us see the result of the TK. If you this is a Higgins and a Barrett, and everyone 0.5, and it is improved almost 30%. Improve the IOL calculation in toric IOL. And this is the non-toric and toric. If you compare this study published in JCRS, if you consider the 0.5 variation, it's improved 2% if you use the Barrett TK. And in the toric IOL, if you use the Barrett TK toric calculation, it is if you consider 0.75 with the limit, it is improved almost 9%. So Barrett TK is a big way, and probably in the future Barrett total keratometry will, TK Universal 2 will be the gold standard of IOL formula. Even in the post-refractive IOL cataract surgery, if you consider the point plus minus 0.1, Barrett 2K TK is giving you almost 92%, 92.5%, 93% accuracy within plus minus 1 diopter. I think this is a huge success of this this formula. Again, if you consider this is published in the SCRS 2019. If you consider Barrett 2K TK, it is almost from if you consider the 1 plus minus 1, it is almost 88% to 96%. It's a huge increase of the accuracy of this, including the TK formula in 2K. So data connectivity also very, very important in important part of the AIOLmaster 700. It capture the image. You can planning device, you can planning dock. You can transfer the data in the cloud. You can plan whenever in the mobile, or you can pass this data into the OT, and you can able to do the markerless surgery. In conclusion, it is give you the precise biometry, and it will give you the perfect planning for the cataract surgery. And it is really, really helpful for if you want to do the premium IOL practice. And one thing I must say, this is only one thing I think this is lacking in the IOLMaster 700. That is, it don't give you the Hill-Warrior formula. And because the Hill-Warrior formula will going to merge as one of the important, because it's a AI based and pattern recognition formula. Thank you so much for your time.
Thank you, Arup, for a fantastic presentation. And soon, I think even Hill-Warrior formula also IOLMaster will be having, and the company has already promised that they will be incorporating into the.
Yeah, that will be great. You know?
Yeah, there were 2 points what I have really impressed about this IOLMaster 700. One thing is, as you are telling about the Morgagnonian cataract. Even there is a Morgagnonian cataract also, you can penetrate and it gives an accurate result. And the second one is about it's a B-scan property. When we compared with the one more competitive brand they kept in the hospital, there is a specificity, but the B-scan penetration of IOLMaster not at all compared to any of the competitive brand. Probably, according to me, this is the best available optical biometer in the world.
Yeah, definitely.
Thank you, Arup, for your wonderful talk. And now we have got one more superstar from Bangalore. Dr. Naren Shetty is the Vice Chairman of Narayan Nethralaya Super Speciality Hospital, Bangalore. And he'll be talking about Callisto, improving the toric outcomes. Over to you, Naren.
Thank you so much, sir. Can you see my slide and hear me, sir?
Yeah, very clear. You can go ahead.
All right. Good afternoon, everyone. On this onset, I would like to thank AIOS and ZEISS for giving me this opportunity. So today I'm going to talk about improving toric outcomes. Now, the toric IOLs have been doing a fantastic job, but how do we improve ourselves? We have been using these manual markers from quite some time, and the errors happen in this because there's no reference point. Errors happen because of head tilt, cyclotorsion. Sometimes you wash the cornea excessively, it removes the mask. But as you all know, every 1 degree of misalignment of the toric lens, we lose about 3% of its corrective effectiveness. Now, when we look at the routine three-step technique of manual toric IOL marking, where the marking first is done on the slit lamp at the horizontal axis at 0-180, then the marking is done intraoperatively at 0-180, and then it's done at the intended axis where the lens has to be placed. Now, when you do this technique with the bubble marker, it has been found that there's a mean error of axis about 2.48 and a total error in toric IOL alignment about 4.98. Now, how do we improve ourselves? This is where the Callisto comes into picture. Basically, this is a markerless system which gives you an intraoperative reference point, taking data from the limbal vessels, which is acquired during the acquisition of the IOLMaster 700, and this is in fact wirelessly transferred to your OT, directly to your microscope, and you can access it from there. Now, it has many features. First, it can show you where your incisions need to be. In the sense, you can plan your main ports, side ports. Let's say if you're planning to correct your astigmatism, the arc or OCC, whatever it is, you can completely plan it, and it'll compensate the cyclotorsion and show you the correct axis where you need to do your marking. And you can do your capsular axis, which is amazing. You can perfectly center it to how you want it and also the size you want it. This is very important, especially when you're operating on a toric patient or a trifocal patient. The overlapping is very crucial. Obviously, it helps us to align the toric lens. And all my toric patients, I always implant a CTR. And as you can see, I implant the CTR under irrigation, and the trailing part of the CTR, I hold it with a micro forceps and place it into the bag. This way, I'm rest assured that it doesn't suddenly slip into the sulcus. Now, why CTR in all my cases? Now, you can see a huge gap between the posterior capsule and the lens. This is the immediate post-op. So this is one of the reasons why there's a higher chance of rotation of the toric lens during the early post-operative period. So when we implant the CTR, what happens is it expands the bag, brings the anterior posterior capsule closer together, and increases the contact between the bag and the lens. As you can see here, there's a beautiful contact between the posterior capsule and the lens. This prevents it from rotating during the early postoperative period. It also has an automated tracking, so if the patient moves his eyes, you don't have to worry. you'll be rest assured the overlay will follow the eye. So this is how it looks like when you're doing a surgery, where you can see these overlay of 3 lines. You just have to align the markings on the lens onto the overlay. Okay, so when we compare marker and markerless, in terms of quantity of vision, actually there's no difference. But in terms of quality of vision, there is a significant difference. In fact, especially in a Toric trifocal, not just, when we test it, in fact, the patients itself, they'll be, telling that their vision is significantly better. A lot of studies have stated the same. It also has features where you can access your IOL Master report, and also has HD recording and a huge storage where you can store all your surgical videos in the machine, in the microscope itself. Now let's get into the patient's shoe. None of us want a patient flow to be long and inefficient. We want the patient flow to be short and sweet. Now let's look at a toric workflow for a manual marker. Now, as you all know, on the day of surgery, topical anesthesia is applied not just once, in fact, twice. That is once on the slit lamp and the second time in the intraoperative period. As you all know, that the more number of times we apply local anesthesia, it is pretty toxic to the epithelium, and you'll have a picture like this. We'll have punctate epithelial erosions, and on the day of surgery, patient will be so much more, will have so much more discomfort. The patient will have watering, redness, a little photophobia also, and also decreased vision on the day of surgery. But when you look at a toric workflow, a patient workflow for a markerless system, absolutely no added step as compared to a monofocal patient workflow. Patient just comes and goes like any other monofocal patient, and he's so much more comfortable. His visual recovery is more quick. And on the day of surgery only, he's very comfortable, and his quality of vision is fantastic. So I would like to conclude by saying definitely markerless system is the future. As the time goes, as the years goes, we always keep trying to better ourselves, have better outcomes. I feel this is the machine which will help us to do that. Thank you for your time.
Thank you, Naren. It was a fantastic talk. I think I do believe in that. Even though I practice in Tier 2 city, I do got this markerless system. After this machine has come into my hospital, the quality of surgery, especially toric intraocular lens and also toric multifocal or toric trifocal, the results has become perfect. Even if you want to plan for if you want to do a LRI also, this exactly gives you have got a whatever the LRI scores you can within the machine, it will tell where exactly you should go. So overall, it gives the most precision, and as you said before also that overall it saves your time also. Not only marking, of course, there is epithelial toxicity, everything is there, but it saves your time also, especially when you are having a large volume like you, or even Arup has got a huge volume of surgery. I think it really makes sense to have this machine. Thank you, Narek.
Thank you, sir.
Thank you. My next speaker is our dear friend, Dr. Krishna Kudlu. He is from director of Prasad Netralayam, and he is a member scientific committee of AIOC. Well, his talk regarding the trifocal of my choice. Over to you, Dr. Kudlu.
Thank you, Arup, for a kind introduction. Can you hear me?
Yeah, yes.
Yeah. Thank you so much. So I'll be talking about trifocals, the way to go. This is my financial disclosure. I'm consultant for ZEISS India. So talking about the natural crystalline lens, it has got good accommodation, clear vision at all distance, glass free, clear vision in all lighting condition, great contrast sensitivity with no rotational asymmetry, with a minimal aberration. So these are the options for presbyopia. You have got lens-based procedure, you have got multifocal intraocular lens, extended depth of range of IOLs, trifocal IOLs, corneal procedures like Presby LASIK. I do a lot of Presbyon. Even there are procedures like supracore is becoming more and more popular in the market, and some of our friends still doing corneal inlays. Even few of our friends in Europe, I met them, they're doing something called scleral spacing device by implanting a PMMA segment in the sclera for presbyopia. Even by applying the erbium laser as a laser-based procedure. So let me come to the diffractive intraocular lens. It utilizes the principle of diffraction in conjunction with interference to create more than one foci. Basically, refractive power is on the anterior surface of the lens and the diffractive power on the posterior surface through multiple grooves on that. So what exactly happens in the diffractive IOL when diffraction is nothing but the bending of light when it is hits and become obstructed. So what happens when the plane waves are transferred into the spherical wave after diffraction? So this is up to the Huygens-Fresnes principle, where spherical wave propagation from different points lead to wave interference. See, now grating density and refraction angle. So the higher the grating density, stronger is the angle of deviation. You can see here. The more rings placed on the lens surface, that means the higher is the add power. So to summarize this, shorter the width, higher the add power, wider the width, lower the add power. Suppose if you have a +4 add on the lens, that means it is almost around 3.2 at spectacle plane. If it is +3 add, that is almost around 2.25 than the spectacle frame. You can see that's what is shown in the figure. So what are the limitations with this multifocal? Because partial spectacle independence, decreased contrast sensitivity. Previously, we used to implant the refractive multifocal IOLs, which is dependent upon the pupil size. There is an increased glare and halos. That's where the intermediate vision comes in, the fact that which was not addressed in the previous multifocal intraocular lens. Especially it was problem for few of the occupations like drivers, computer professionals, and they have to really modify their lifestyle. So this is where this trifocal come into play. Probably I feel it's a need of the hour. So this is the design. This is the first generation bifocal IOL. You can see where a lot of rings were there, then become the second generation bifocal. Then this is become the third generation trifocal of small and the larger wedges on the intraocular lens. So this is about my talk today about the Trilisa 839MP trifocal from Carl ZEISS. So this is here the near addition is 3.3 and intermediate addition is 1.66. That improves the intermediate vision without compromising the near vision. This design for reduced potential visual disturbance and improved night vision. So the very important about this lens, the light transmittance rate is almost 85.7, which is the highest compared to any of the lenses. And the technology, what they do, this lens is something called SMP technology. That means smooth microphase optic design, which is ideal optic image for the ideal optic image and also for reduced light scattering. So as I already said that, see, equal light distribution for distance, intermediate and near. So this is very good for especially those are young patients, those are not, even you can, especially when you're implanting for young pupils, this is most important. And because of the light distribution in all this condition, I think even it is optimized for night driving and reading in the low light. The one more advantage of this lens is especially for PCO protection. This is a hydrophilic with a hydrophobic surface. Along with that, there is an anti-PCO coating on the posterior surface of the lens that prevents the PCO. This is one comparative study with the other competitive lens, apatized bifocal IOL with the lens. Comparative optical benchmark measurement using in situ model to compare the intermediate vision quality AT-LISA and the other lenses. You can see how AT-LISA behave in as a intermediate vision is concerned. So this is about the, no, I have got 12 minutes talk, just hold on. So this is about the LISA Tri maintains the resolution of efficacy contrast in the low light condition. This is how it behaves as far as the near vision is concerned. Patient will be able to clearly focus back forth at object at different distance without the need to put in corrective glasses. So this is about the loading system. I want to show you here. It is a blue mix injector. It can go through easily with 2 mm incision. First you inject little bit of viscoelastic, take the lens. So you will not be touching the lens at all. Directly go into the groove there. You will, when you're going here, you put it there, press it, you will hear a click sound. Then you take out the cap, then you can take out the cap, put some amount of viscoelastic here, go ahead with the injecting system. Why I am showing you this video, you can see the pupil size is very small here after the phaco. Still, how nicely it is going through this pupil without any trouble. So the injecting system is fantastic, and since it is a hydrophilic with a hydrophobic surface, it's a truly a MICS compatible lens. These are our results of 76 patient, 132 eyes. What you can see is uncorrected with the best corrected visual acuity. You can see here the end of the 2 years also, the not much spherical the sphere is remaining in the patient. If you see the intermediate visual acuity also, it is maintaining very well. This is about the uncorrected near visual acuity. In the end of 3 years, patient is maintaining the good vision. This is about the defocus curve. And when you compare about the glare, quality of vision, how much of the percent of the patient experience? Only 20% of the patient had a little bit of glare, but remaining all the patient doing really well. And only 5% of the patient really bothersome. And only 6% of the patient actually really required to wear the glasses. This is about the trifocal Toric, that is a 939 model. The results are quite similar. But what I want to show here about the astigmatism, only 2% of the patient had a astigmatism remaining around 0.76, and only 3% had around 0.5, only 15% had around 0.2 astigmatism, but more than 80% of the patient cylinder is perfect. Once again, thanks to AIOL700 and also the Callisto system, what is there in our hospital. More than 95% of the patient had a refractive astigmatism less than 0.5 diopter. In conclusion, trifocal intraocular lens implantation can perform by any cataract surgeon who is aware of the principles of refractive surgery and handles the precise IOL calculation. AT-LISA TRI demonstrated an excellent functional vision at distance, intermediate and near in our all clinical evaluation. Almost all patients enjoyed spectacle independence after AT-LISA TRI implantation in our clinical evaluation. I thank ZEISS for this opportunity. Thank you. So next we'll go ahead with the other speaker. That is Sartaj Grewal. He's a young dynamic surgeon from Chandigarh. He'll be talking on my experience with 3D visualization microscope technology, RTY800. Over to you, Sartaj.
Good afternoon, everyone. I hope I'm audible.
You are audible, Sartaj. You can go ahead.
Perfect. Thank you so much for the kind introduction, sir. So good afternoon. I would like to first thank AIOS and ZEISS for this opportunity today. So today I'll be sharing my experience with 3D visualization surgery with the RTY800 by ZEISS over the last year and a half. So the RTY800 is an evolution of the Lumera 700 with digitalized optics. The stereoscopic image is viewed on a 55-inch 4K 3D monitor by Sony. It is probably the best medical grade monitor that is available as of today. So this setup provides you with a very comfortable heads-up position, and your entire OT team can be engaged with the stereoscopic view of the surgery. So we are all very comfortable with the view provided by our operating microscopes. So comfortable, in fact, that we never notice the tunneling effect that is produced by the microscope optics. It is only when we escape from the tunnel and experience operating on an entirely new platform that we realize the difference. One of the significant advantages of moving over to digital optics is that the cameras allow us to operate on much lower illumination intensity than we would on a traditional microscope. You can very comfortably operate at only 20 to 30% illumination intensity, improving comfort for your patients, particularly those under topical anesthesia who are trying to focus on the light itself. This can also reduce the chances of photic retinal damage during longer surgeries. The image seen on the screen has excellent contrast and colors, which you can also adjust as per your preference. One of the digital optics provide an improved depth of field compared to traditional microscopes, allowing us to comfortably perform an entire cataract surgery without requiring to adjust focus. The digital platform enables excellent stereopsis that can be calibrated as per the surgeon's comfort. So while frequently switching between the Lumera 700 and the Artivo while operating over the past year, one thing that I've noticed is that even with the same magnification levels on both the microscopes, the image that is formed on the large screen is actually bigger than what it is when you view it through the optics. That allows you to see more detail and operate more comfortably. So the Artivo provides an operating view with excellent resolution, even at high magnification levels, that allows you to see even the finest of details, such as these cortical matter strands. And even at high magnification levels with more movement, you can perform delicate steps with excellent vision clarity and no delay or latency. With the digital optics, you can increase the magnification levels, but the reduction in depth of field is not as much as it is in a conventional optical microscope. There is no noticeable lag in the display. Only rarely, when the microscope is auto-adjusting the image to changes in the field of illumination, that we can have some amount of lag. But in a surgery like cataract, where the background is quite evenly illuminated, we really never notice this. So operating on the Artivo does not increase your surgery time as compared to a conventional microscope. Now, as far as the learning curve for heads-up viewing is concerned, one advantage that we all have as ophthalmologists is that we are very comfortable using microscopes. So our eye-hand coordination is already dissociated. We are able to coordinate our eye-hand movements without looking down at them. So the only adjustment that is required is a slight rotation of the head to look at the screen instead of the binoculars. Now, occupational musculoskeletal disorders are very common among ophthalmologists, with more than half the surgeons surveyed in one study reporting neck and back pain. 15% of the surveyed surgeons actually had to curtail their work as a consequence of these problems. So when viewing from the binoculars, due to the position of the operating chair, the patient's eye, and the microscope eyepiece, we find ourselves having to constantly bend forward to reach the eyepieces, leading to aching and strain on our backs. However, by viewing on the monitor instead of the binoculars, we can sit more upright, keeping our back straight, improving comfort, eliminating the need to constantly bend forward, and reducing strain on our backs. Another significant advantage that I've noticed with heads-up viewing is that normally we have to adjust the chair height so that our legs slide under the table, our hands comfortably rest in the plane of the surgical field, and our eyes reach the eyepieces comfortably. Now with heads-up surgery, I have more freedom to adjust the chair height, as I don't have to worry about reaching the eyepieces or needing to lean forward constantly. So I can actually keep the chair height slightly lower, reducing stress on my lower back and shoulders, making me more comfortable. One significant advantage of the Artivo over any other heads-up viewing platform is the hybrid mode. So if you're operating and for any reason want to switch back to the oculars, all you need to do is rotate this small knob on the side of the microscope, remove the 3D glasses, and you can start viewing through the oculars. But the greatest part is that everybody else in the OR can still continue to view the 3D image on the monitor. You can almost seamlessly transition between heads-up and oculars. Although in my experience, I have never felt the need to switch to oculars during a surgery. Another advantage of transitioning to the heads-up viewing is that you no longer need to adjust all the different settings, such as the interpupillary distance, or the refractive error, or the high eye point position on the inclination of the binoculars when you're switching from one surgeon to the other. Now, this dramatically improves comfort for all the surgeons using the OR and reduces the chances of the surgeon facing difficulty during the surgery because someone forgot to change the settings to the surgeon's preference. Now, where heads-up technology truly shines is in the process of training young surgeons. Some of the advantages offered are that the stereoscopic view is not limited to just one resident at a time. Everyone can enjoy the same view and learn from it. It is also far more comfortable for the trainee who's assisting you, especially if there is a significant difference in height between the primary surgeon and the assistant. The advantages carry forward beyond the OR with the ability to demonstrate surgeries in lectures with stereoscopic videos, dramatically improving the ability to explain the nuances of certain surgical steps, such as chopping during phaco. So we compared the complication rate between two groups of trainee residents, where one group performed all the surgeries on the Limera 700 and the other group performed all surgeries on the Artivo 800. And we noticed fewer complications with the group operating on the Artivo. And one reason for this is that even the trainer has a better view and you can intervene earlier. And as discussed earlier, when you're switching between surgeons, it can be easier and also quicker, which can help you save time in salvaging the complication that might occur. So training surgeons, young surgeons who are undergoing training, they were actually able to perform complete surgeries all the way from making incisions to hydrating them using only the heads-up view. not needing to revert to the oculars even once during some of their very first few independent surgeries. This clearly demonstrates the superior heads-up visualization and comfort provided by the article. So while we have talked a lot about the heads-up technology, which allows you to stay connected to your surroundings during the surgery, let's talk about the article's connectivity with the rest of ZEISS's cataract suite. So Dr. Narain has already discussed this in his presentation, but with all the digital investigations and operating platforms and connectivity, now data transmission between all these different devices has become completely seamless. And with the Forum and EQ workplace, we can securely access our patient's data from anywhere. Now, one great advantage is that you can view and edit biometry data from any room. You don't have to keep going back to your biometry room to the IOLMaster 700 to view the data and edit it. Neither do you now have to rely on your technician to be able to edit the data correctly as you desire. So this can help in reviewing surgical plans preoperatively at home. And particularly this easy access to data is great for researchers and can improve their productivity by reducing the time spent in data aggregation. It also makes it easier to retrieve data when you're planning your presentations. From the patient's perspective, the workflow and their time spent through different steps in surgical planning can be dramatically reduced. For example, if you're planning a patient for a toric IOL with a conventional platform, you would have to execute a minimum of 6 steps to complete the process. With digital operating tools and a completely connected platform, you can reduce that to only 3 steps, half of the traditional process. This can tremendously reduce patients' waiting time and increase your productivity. Shifting to the Artivo has improved my toric IOL outcomes. One of the reasons for this is that viewing the digital markings for the Callisto on the large screen is far more comfortable than viewing it through the eyepiece. The information is still visible only with one eye, same as with the eyepiece, but the dissociation caused on the larger screen is far less noticeable. Another reason is that aligning the lens with the large calipers is also easier on the screen, and also the accuracy of the Callisto software itself seems to be better than what it was in the previous generations, possibly because of the high resolution cameras that are being used. Now, there are certain points that are being worked on and improved with the digital platform. For example, reflections from the operating microscopes. Now, there are solutions such as low reflection instruments which are available, but it still does require something, maybe even a software improvement to be able to overcome these. And some artifacts on the ocular surface, such as meibum, can pose a challenge with traditional microscopes also. But there's always, again, the scope for software upgrades and digital filters to help reduce such phenomena in the future. Some of the improvements we can expect with advances in hardware over time is faster auto-image adjustments, further refinement of image calibration, and sometime in the future, maybe even cameras that are based on newer image modalities that can help us assess and improve the fluidics flow while operating, modalities that can assess excessive tension on the mobility of the posterior capsule and warn the surgeon in anticipation of complications. We can have dye-free digital capsule staining, which can be made possible. We can have the machine can actually be trained with surgical videos and can again help us anticipate possible complications during the surgery and warn us before the complication actually occurs. There are a few points one needs to consider. Firstly, accommodating the large 3D monitor will require some modifications to your OT setup. The higher resolution recordings, you will need to upgrade your entire recording system and also increase storage for the larger files. If you are myopic, ZEISS does provide 3D glasses with inbuilt prescriptions, or you can also comfortably use this specially designed 3D glasses over your own existing glasses. But you also have to importantly train your staff to handle these glasses to ensure there are no smudges or fingerprints on them. Otherwise, they can really interfere with you when you're operating. Now, as with any new technology, the strain on financial resources is significant and needs to be thoughtfully considered. But to sum it up, the advantages of heads-up viewing technology are best experienced rather than explained. And having frequently switched between heads-up and oculars for over the last year and a half, I can definitely say that I preferred the comfort and visualization provided by the heads-up technology. And over time, I'm sure scientific data will also be available to substantiate this. I actually now experience some strain and backache when I operate on my list on oculars. And it never happens when I use the Artivo. That is my own personal experience. And we do need to understand that heads-up technology opens the avenue to incorporate many new technologies into cataract surgery that were not possible with traditional microscopes. This technology is here to stay and adoption will definitely increase over time. Thank you.
Thank you, Sartaj. Excellent talk. I think I'm also very much aware of this. This is a fantastic equipment, actually. Those who are like people like me, I am suffering from disc prolapse neck, disc prolapse back. I think so many times I got admitted in the hospital. I never got my surgery done. But as you said that, once again, the cost effective is slightly on the higher side, I think. But apart from the cost effective, all advantages are there with the RTO 800. But one question to you. See, when you got RTO for the first time, previously you are operating under the regular microscope Lumeri. How many cases it really took for you to get adjusted to this particular system?
Honestly, I think one case, maximum two. By the second case, I was completely on the heads-up display, not using the oculars. It really takes you by surprise how naturally it comes. Because, again, we're already used to looking up and operating down here. We're not used to looking at our hands. So we already have that dissociation. All you have to do is, instead of looking through the oculars, just shift your head, look at the television. The view, the depth perception is just perfect. But yes, some people, their experience might vary, because basically the offset that is there between the two 3D cameras has to be adjusted to your own stereopsis level. So that can vary. For us, whoever was working at our clinic and using the microscope, it just clicked from the very first day. Nobody struggled. But sometimes during transit, you can have a little maybe variation in the position of those cameras, which needs to be adjusted. But the team from ZEISS is always there. They'll be there to help you through those first few cases. But in my personal experience, I will say first, second case, I was perfectly, it seemed very natural.
Do you have OCT, which is incorporated in 800?
No, we have not gone in for the intraoperative OCT in our model.
It's available in the market also.
It is. And I think maybe actually our machine is the only one without the intraoperative OCT. Okay. Personally, I feel that the intraoperative OCT is going to see a lot of improvements and changes within the next few years. I still feel it needs to be a little faster to really be useful.
Thank you so much.
KP, actually, sorry for joining in late, but I have a very pertinent question to Prasad.
Hello.
Yeah.
Sir, you can hear.
Prasad, I have a very important question for you. Yes, and that's a question that all of us actually ask ourselves before we go in for these high-end equipment. So the question is, do I justify this high-end equipment to my clientele? Or how do I justify? Do we charge more for these high equipment use, or is it cross-subsidized as always? So, and when is the necessity of this high equipment? When, just like we answer for femto, okay, femto cataract is a necessity when it's a dark brown cataract. If you have it in your armamentarium, you push for it. You push your patients that, why don't you go in for this? If it's a subluxated, if it's a PPC, femto is a better way, a better technique. So similarly, the 3D microscope that you have been talking about, how would you justify its use? And do you think it's going to become very, very common to all of us, obviously with the financials coming down? Sartaj.
Yes, sir. So first of all, I actually do not really mention this to most of my patients, because there are very few who would actually understand and appreciate the difference that it makes. From my perspective, the main advantage is it improves my comfort. I can do longer lists with less strain on my body, because I operate in the morning and then I do my OPD after that. And I can do that easier. And again, like in my presentation, I showed the study that 15% of ophthalmologists who were surveyed in 2005 actually said that they had to curtail back their work. Dr. KP Kudlu is mentioning that he has back problems. Sometimes we have to invest in something to actually make ourselves more comfortable, improve our productivity. It is not necessarily one of those things where you're looking directly at your return on investment. It will be cross-subsidized, no doubt about it. But yes.
So that is the importance of the cross-subsidy. It is for the surgeon's benefit that we should come on to this important platform so that we can deliver more. You have said the absolute right thing. It is the delivery of the surgeon and the health of the surgeon that's first and foremost. You have to be healthy. Your spine has to be healthy. So this is a better technology to get you onto that health.
Yes. And secondly, for training. when it comes to training residents, it makes a big difference because like I remember my days at RPC, one resident is washed in and viewing from the oculars while everybody else is lost running around. Over here, everybody can be engaged. You can, because many things, especially like in just how to chop a nucleus, when you see it in 3D, you really understand it. So I think from a training perspective, it's much better. And also the other thing is when you're training someone, if you're just sitting right there, you tend to be more obtrusive. You tend to keep interrupting them that, no, here, let me do this. But when you over here, you can actually get up, take a few steps back, view it on the monitor, and it gives the trainee also a little more independence and confidence that, okay, I'm doing this on my own. So the training is the second thing where it really, really highlights. And coming to the third thing as far as cost, as you mentioned, like with any technology, this is something that will trickle down to, even the microscopes that are lower down in the range, because the technology itself is fairly, once you have the optics down, the remaining back-end technology is fairly easy to incorporate. So I'm sure we will see trickle down to more and more microscopes.
Thank you. Thank you very much, Taj. KP, let's have
thank you so much. Next. It was really, sir, Partha sir came in and gave a big boost to our session also, given your vast bit of knowledge to this particular session. So going ahead with our last talk by Dr. Neeta Shah. She's a leading leading phacosurgeon from Mumbai, runs the clinic called AIOC Clinic. She'll be talking about managing astigmatism and choice of my toric lenses. ZEISS 80 laser tri-toric and 80 laser toric. Over to you, madam.
Good afternoon, everyone. I would like to thank all the organizers and ZEISS for having me here. Am I audible and is my screen visible, Dr. Kudlu?
Very well, ma'am. Very well.
So I would be talking on the management of astigmatism and the choice of toric lens, which is 80 Torrid for the monofocal and 80 laser tri-toric for the trifocal lens. So first of all, why do we need to do all this? Today's expected standards in cataract outcomes from the patient's point of view is they want uncorrected visual acuity, excellent visual quality, which is restored immediately with minimal or no spectacle dependence. And we can only achieve this by getting reliable refractive outcomes and astigmatism correction. The reason being that up to 70% of our cataract patients have some amount of astigmatism which needs to be looked into. And post-operatively, if this is not addressed, then at least 40% have it remaining, only 60% achieve less than 0.5 diopter. If the vision is 20/20, we can be very sure that the astigmatism was less than 0.5. The moment it goes to 0.5, the vision is not absolutely optimal that we would like. And this is a very, very gross idea of what the vision is like if there is even some amount of astigmatism which is left behind. And this is where we have patients who are not so happy. The various options that we have would be the limbal relaxing incisions manual or the femtosecond arcuate incisions, lining the incision on the steep axis, and toric IOLs, out of which toric IOLs are the most reliable ways in which we can look after astigmatism in a patient of cataract. So for this, we need to have proper armamentarium to work up our patients with the form of good keratometers, optical biometers, and of course, a topographer. Even in the basic examination, we have to see to it that we don't miss out on anything which gives us a suboptimal result. This becomes very, very important when we are planning a trifocal lens where the visual quality which the patient expects is exceptional. And the cases where we would not do it are mentioned here. We all know about them, but especially keratoconus irregular astigmatism, we would not wish to do a trifocal lens. This is absolute basic, but I still felt I should mention that we see that the patient is off contact lens. We take a measurement after a natural blink. Measurements are done on a day when there is no digital tonometry, etc. being done, or we don't touch the cornea for a pachymetry or anything. Even if we have other topographers use, we don't use those Ks, and our A constants need to be optimized regularly. even the axial length, we need to see that we have a good number of consistent measurements. Adequate signal reflex ratio should be achieved. And we remeasure if we find that there are some outliers or where we find that the data that we are getting is not consistent, and we need to reconfirm what we are doing before we proceed. Keratometry is rechecked in very flat, very steep corneas. Also, if both the eyes are not matching, and if it correlates poorly with whatever the patient is already wearing. So this has already been talked about, but I think that we cannot keep on not highlighting the use of this beautiful machine, especially from the point of view of having a swept source OCT giving us the posterior cornea data, which even in my journey in Contura, I've seen that it is just not the anterior cornea which is important, it's the posterior cornea too. And we need to remember we are going to leave it behind, it's going to be in the eye. And that is what we need to factor, which the IOLMaster 700 helps us to do so beautifully. Because if we take data from other devices, they are not been tried and tested with the trusted formulas and constants. So it's much better that we have the data from the IOLMaster 700. And it is such robust, good data that we have, so reliable, so reproducible, and so easy to get it from the machine. And when put into our calculators, etc., it gives us such reliable data. And by doing this, we are replacing the posterior surface model with the actual posterior corneal measurement. And having an online calculator like the ZCal, the ZEISS calculator, it gives us fantastic outcome prediction. It gives me the option of comparing both the eyes, and I can put in the total keratometry or the TK value directly and get an optimal lens power, which is decided by this particular calculator. Now we have done our tests, we've done our calculations, but it's very important that there is a precise alignment, a precise lens, which gives us a long-term stability in the surgical result that we achieve. That is possible with an image-guided system. So the difference is in getting a quantitative and a qualitative outcome. We have more satisfied patients because we've been able to do our job more thoroughly, and it gives an excellent outcome when we use an image-guided system to help us with the journey. So this is just an example of how this would really help us. We have the image of the eye where we can put in the data and analyze it. Head alignment and axis changing is something we are all aware of. And because here we have a reference image which gets re-registered in the operation theater, the head tilt, etc., does not change the result outcome that we have. We are all aware that a 15-degree and a 5-degree clockwise head tilt would result in a 12-degree or a 5-degree change in the clockwise rotation, and similarly in the anti-clockwise rotation, and that is why this becomes important. Also, it gives us an idea, the way our ZCal does also, how the residual cylinder changes with incision location. If the surgeon wishes to do that, we can adjust that and decide prior to surgery what we want to do. Here, I just wanted to show a case which we had recently where it showed a lens which was T5, axis of placement 126, and on the image guided system, it showed a T3 with 20. I have picked this up at random just to show the importance of an image guided system. And when we saw this huge difference and went back and checked the data, the technician had forgotten the point decimal and put the SIA as 3 instead of 0.3. So this acted by corroborating the data which was there in the online calculator, even though it had been checked, but this saved us from creating a havoc result. So the monofocal lens that we have here, the 80 Torrid, is bitoric with toricity on the anterior and the posterior surface. And this increases the effective optic size for the higher diopters with a phenomenal diopter range of lenses available, which makes life much simpler with excellent image quality. with 91% of the patients up to 4.5 diopter correction showing less than 0.5 residual cylinder, and for the higher ones up to 84%, which is an excellent result to get. Also in myopes, where the bag is big, the assessment for the rotational stability at 6 months after implantation in axial lengths greater than 25 and less than 27 has been shown to be excellent. I do a couple of things in these cases. One is I see to it that I put a CTR ring in patients who are high myopes. I don't leave it without a CTR ring, giving the lens an opportunity to rotate. And where needed, where I find there is some amount of jiggle, I do use an air tamponade also, and touch wood, so far I have not seen rotation. Now we come to the trifocal toric lenses, which is a challenge because these are the patients whose expectations are high and we have to be bang on with our results. There is no scope of error. We look at any pre-existing corneal astigmatism, which is 0.75 and above, and even 0.5 if the flat axis is such that it would increase. And we take a call as to which lens to select as per the calculations which proceed. This is a beautiful lens with a 360-degree anti-PCO barrier, add power for reading as 3.33, and for intermediate 1.66, with an excellent injector as been demonstrated earlier. And it has a 4-point haptic design, and it's available in 0.5 cylinder diopter steps with a huge range. And in the workflow, it can be rotated in both the directions, which is an advantage. SMP technology gives no light loss, no light reflexes, very little scattering, and no refraction errors created. Now, this is a screen which shows us the effect of astigmatism. So these are the spots focused by the multifocal lens. This is what happens in the case of astigmatism. And when we can correct that astigmatism, we again get nice point sources of light where the intensity is only decreased by 20%, which is a very, very good lens to use. This has already been discussed. We have an excellent defocus curve and we have good near, intermediate, and far vision distribution. What we need to take care of in the theater, these are just a few points that I stress on, is the rexis size, which should cover the optic all around. Aligning the lens a few degrees away till the viscoelastic is removed from below the lens completely, and the polishing, whatever has to be done is done. And then the alignment is done along with the rotation of the lens, concentrating on the parallax, which is proximal in case a imaging system is not being used, tapping the lens in the center at the air, sealing the chamber very tight because most of the rotations are in the immediate postoperative field. So not everyone wishes to give this importance, but we need to remember for every 3 degrees of axis rotation, 10% of the cylinder power is lost. And if we are above 30 degrees of rotation, we would be inducing a cylinder, and we need to be cautious of that. The contraindications are preoperatively, as said before, intraop is PC rupture, zonular damage, and also if there is no 360 degrees overlap. This is possible, this type of technology is possible because we are concentrating on the biometry, the analysis, planning the surgery, marking well, taking care of cyclorotation, factoring the SIA, having a rexis marker, positioning the lens, and in the end, analyzing our post-op results so that we can only become better. We need to take care of all the variables. They may be very small at each level, but if all are added, there is a lot of opportunity for error. The technology of the image managing system and the ILMaster 700 has allowed us to take our results to an excellent level in the last few years. So to summarize, managing astigmatism leads to better surgical outcomes in premium IOLs. The innovative ZEISS designs give excellent results. Patient satisfaction with premium IOLs increasing due to better technologies, better lenses that we have, and excellent results. Thank you for having me here.
Thank you, Dr. Neeta. It was fantastic presentation, madam. As you said that, see, we have done actually one study patients for one eye, we have implanted 80 Torby 709 and other eye we put one more other brand with the C loop. The overall the predictability about this particular platform is a 4 haptic platform. Yeah. It gives a very much centration, and the post-op rotation is hardly you will see. There is no post-op rotation. Previously, I used to speak about this lens 5 years before. A lot of our own senior colleagues used to have fight with me in the podium, telling that no, these lenses rotate in the back. Now the same colleagues, they are implanting in a very high number. They tell that the rotational stability is ultimate with the 4 haptic lenses. I used to tell since beginning last 5-6 years, my 100% toric lenses are 80 laser Torby lenses because of its rotational stability. And one more feature.
Actually, Dr. Kudlu, there is a study in JCRS. I remember this is 2012. They compare the Alcon model IQ with the Technics model, Technics Toric, IQ Toric, and the plate hefty design of the star. And their study, they are showing that the rotational stability least in the plate hefty design in the star model. But this is a different kind of model in ZEISS. This is a absolutely rotational stability. And if you really, if you want to rotate in the postoperative pure, if there is an inhalant, you can realize how difficult to rotate in the back. So it is an absolute. Whenever any lens is very difficult to rotate within the back, that means this lens is stable in the rotational swell.
It is sticking onto the very well, sticking onto the PC very well. And one more feature of this particular toric, it has got a toricity both on the anterior and the posterior surface.
Yeah.
So the accuracy of this toricity is much better compared to any other lens available in the market.
So even I have had this discussion with colleagues a number of times because they would be surprised with my saying that I don't see rotation and I find it very stable. So a couple of times when junior colleagues have discussed with me, I've realized that their visco removal was not up to the mark, and being a plate haptic like lens, it would trap it more than what a C loop would. And also they have not kept a watch on the lens power, where I do use a CTR ring for anything which is 16 diopter and below, or axial length 25 and above, because this just adds to collapsing the bag and preventing rotation. And I'm doing it just so that I don't want it back. But earlier when I've not done it also, I've not had any patient who has actually rotated.
So visco removal is the key in any of the premium IOL, as you said, madam. And since even I had implanted in a very high myopic with the cylinder, still the rotational stability is very good in spite of I have not used CTR in those cases. So the other C loop toric lenses, if you want to put in a very high myopic, then you have to put CTR because of the rotational asymmetry. But here you need not have to put it, straight away stick onto the PC. Any questions? Thank you so much. Thank you so much. Dr. Partha has come. Any comments from our chairman scientific committee?
I just have a question. I have a question to Dr. Partha Vishas. If any practitioner want to upgrade his practice, he's a fantastic phaco surgeon. He want to upgrade his phaco machine and the biometry machine. Which should he give the preference first? Biometry machine or phaco machine?
Fantastic question, but you have answered it first. He's a fantastic surgeon. He's a very good surgeon already. That's what you have committed, right? If he's a very good surgeon, what he does not have control over is his biometry. So the biometry as of today, to get us onto that particular platform and accuracy is what is required for a fantastic surgeon. However, if he's not so good a surgeon, and is practicing in a place where he has got a very high volume of surgery, there again, the need is for a very good phaco machine. The first priority, the need for a very good phaco machine, so that ease of comfort, the good options to be given and the good outcomes to be given to the patient is first and foremost. Then comes the biometry. The biometry of today, even the ultrasound biometry of today, which we use at times or different centers, not so bad, not at all. We get on, but for the perfection, we want the optical, we want the other additions. So we need to understand, we have to customize our priorities with our practice. So that, I think, is a very important take-home point for everybody. Very general point, very, very general,
yes.
But I think it's a need.
Sir, one point from my side, actually, as a phaco surgeon, those who want to start their practice first, initially, in that moment, you need a very good phaco machine, that is higher end. But once you become the best, I think even the simplest of the machine, you can do the phaco. But the thing is, when you start your practice, you cannot buy that higher end machine because of its rate and expensive.
Yeah.
So that's how it goes. But nowadays, because of this, a lot of fellowships, students coming out, their skills are very good. I think any good phaco machine do the job.
Quite true. Very correctly said, KP. Because when we started our phacos, we did it on today's gradation. We did it on 3rd grade machines. We learned our phacos in 3rd grade machines. So our learning phase was very, very long and steep also compared to the guys of today who learn it in the best machines, in the best training centers. But that's important. The best machines, the best training centers to give you on board. You're already at this level. So when you go into your practice and if you're operating with lesser phaco machines, you still are doing a good job. So I think these are the benefits of what we have today.
Thank you so much, sir. It was a wonderful session. Once again, I thank our chairman scientific committee and the whole scientific committee for including this very good session. Do
you include yourself, Kudlu, also?
Thank you, sir. And also I thank ZEISS for the opportunity to include in the program. Thank you.
I must say ZEISS has always been very, very understanding of the requirements of surgeons and so many other companies also. But this is very important. The trade and the science should go together. The science to the ophthalmologist has to be translated, and thereby our companies have to come in and do the job, which they are doing at a very good level. Of course, for the Indian scenario, you need to think about the finances because we are not as rich in India as in other parts of the world. And that's something to ZEISS.
Thank you, sir.
Thank you.
Thank you very much. Thank you, KP.
Thank you.